Hi there. Today I'm going to be talking to you about post-traumatic stress disorder, the causes, symptoms, assessment, treatment, and treatment outcome measurement. Firstly though, I'll start by informing you of what a normal response to trauma is. A person who goes through a potentially traumatic event, such as rape, armed robbery, or witness to murder, is likely to experience a traumatic stress reaction. A normal and adaptive reaction to trauma can last for days or weeks after the traumatic event. Many people show lingering signs of alarm and distress, such as feeling stunned, fatigued, and emotionally unstable. This can disrupt functioning. Within 1 month, most people who are exposed to potentially traumatic events recover, whilst others develop post-traumatic stress disorder. So why do some people develop post-traumatic stress disorder, whilst others do not? How people manage and cope with trauma greatly influences the risk for PTSD. Individuals who are particularly avoidant, who cope poorly with various symptoms by using alcohol to self-medicate, who are isolated with few resources, or whose recovery environment is particularly harsh and rejecting, are less likely to recover adaptively. The longer a person suffers and is impaired, the greater the likelihood of chronic and treatment-resistant PTSD. From a cognitive behavioural perspective, psychological problems begin when people try to suppress and avoid thoughts and feelings about trauma. The avoidance of thoughts and feelings prevents emotional processing of the traumatic event, which may drain cognitive resources, increase arousal, and lead to paradoxical increases in the intrusive thoughts. The avoidance of thinking about trauma may be supported by catastrophic expectations about what might happen if the person allowed him or herself to think fully about the event. And recovery environments that are filled with financial, marital, family, and physical demands have been associated with greater risk for chronic PTSD. The characteristic symptoms of PTSD are multidimensional. There is a persistent re-experiencing of the traumatic event by intrusive, distressing recollections of the event, distressing dreams, and flashback experiences. There is also persistent avoidance of stimuli associated with the trauma and numbing of general responsiveness. Finally, there are also persistent symptoms of increased arousal, as indicated by difficulty sleeping, irritability or outbursts of anger, difficulty concentrating, and an exaggerated startle response. PTSD is divided into acute and chronic. Acute PTSD can be diagnosed 1 month after the event occurs. When PTSD continues longer than 3 months, it is considered to be chronic. Chronic PTSD is usually associated with more prominent avoidance behaviours, as well as with more frequent co-occurrence of additional diagnoses such as social phobia. In PTSD with delayed onset, individuals show few or no symptoms immediately after the trauma, but years afterwards they develop full-blown PTSD. If a person is suspected to have PTSD, the client must be assessed by a psychologist before treatment can be administered. There usually need to be a few sessions worth of initial assessment before treatment can begin. In the first session, it is recommended that a psychologist conducts an initial screening evaluation of trauma history, treatment history, PTSD, and comorbid problems using the initial section of the structured clinical interview for DSM-4. This section frames the presenting complaint in the life course context and screens for other significant problems that may need intervention. The The goal here is to screen for psychological and social problems, screen for lifespan trauma, and evaluate current resources and social context. The psychologist can get an initial idea about whether the PTSD is a primary problem and whether the person is appropriate for problem-focused cognitive behavioural treatment. If so, the psychologist can begin to hypothesize about specific PTSD-related problems that may be the first target of intervention. An additional goal is to provide an open-ended format to allow the client to articulate history and current status in his or her own way, which can reveal useful things about interpersonal and communication style and coping capacities. An open-ended format is also useful before structured interviews and tests are employed because it empowers the client and allows him or her to get a sense of the psychologist as a person, which can be comforting. The client should be given paper and pencil questionnaires to fill out at the end of the first session. These should include the Beck Depression Inventory, the Beck Anxiety Inventory, the 36-item short-form health survey, a screen for lifespan traumas such as the Traumatic Life Events Questionnaire, and the Post-Traumatic Stress Disorder Checklist. The depression and anxiety measures are important because these disorders are common co-occurring disorders with PTSD. The health survey is important in case there are other health problems which may contribute to symptoms of PTSD. It's important to screen for lifespan traumas to be sure that the psychologist is treating the specific trauma which caused the PTSD. The Post-Traumatic Stress Disorder Checklist is a measure of symptoms and permits diagnostic decisions using the DSM. If possible, the psychologist should score before the second evaluation session and use the results to guide the next phase of assessment. The majority of the second session should be devoted to administering the clinician-administered PTSD scale. This assesses the 17 DSM symptoms of PTSD, as well as 5 associated features of PTSD, including trauma-related guilt, survivor guilt, reductions in one's awareness of surroundings, derealization, and depersonalization. It also provides ratings of the impact of symptoms on social and occupational functioning, the status of PTSD symptoms relative to an earlier assessment, estimated validity of the overall assessment, and overall PTSD severity. During the interview, the psychologist should take notes on factors relevant for a functional analysis of trauma-related behaviours. Before the third meeting, the psychologist should have a working formulation of the client's unique adaptation to trauma and be able to determine the patient's appropriateness for interventions and prioritise targets for intervention. The psychologist should collaborate with the client in coming up with a treatment plan and provide the client with accurate expectations about the course of treatment. Usually, treatment consists of a period of psychoeducation and self-monitoring, followed by stress management and exposure therapy. Psychoeducation would involve providing the client with information about what PTSD is and how it can be treated and managed. Clients would then be instructed to self-monitor intrusive trauma-related emotional and cognitive responses on a daily basis. Clients should write down where they were, what they were thinking about, the degree of negative affect they experienced, and their coping response. This is important so the client can gain self-awareness of their own symptoms and triggers for symptoms. The client may also gain a sense of control, and they're able to predict which thoughts and events are likely to cause symptoms to occur, so they're able to be prepared with a more appropriate coping response. The information gathered during the self-monitoring is also useful to guide the focus of stress management. Stress management may involve progressive muscle relaxation, where the client is taught to become acutely aware of any tension in their bodies and counteract it by relaxing specific muscle groups. A number of procedures focus attention either on a specific part of the body or on a single thought or image. This attentional focus is often accompanied by regular, slowed breathing. Meditation could also be used to reduce stress, as people who meditate for 10 to 20 minutes a day report feeling calmer or more relaxed throughout the day. Cognitive therapy should be used alongside relaxation therapy to identify distorted thinking and challenge the client to evaluate his or her thoughts and replace the distorted thinking with more accurate or logical thoughts. Once the client's stress is managed, most psychologists agree that people with PTSD should face the original trauma, process these intense emotions, and develop effective coping procedures in order to overcome the debilitating effects of the disorder. The trick with exposure therapy is to arrange the re-exposure so that it will be therapeutic rather than traumatic again. A traumatic event is difficult to recreate, so the client is instructed to imagine the event so that the content of the trauma and emotions associated with it are worked through systematically. At present, the most common strategy to achieve this purpose is to work with the client to develop a narrative of the traumatic experience that is then reviewed extensively in therapy. Cognitive therapy to correct negative assumptions about the trauma, such as blaming oneself in some way, feeling guilty, or both, is often part of treatment. Trauma clients often repress the emotional side of their memories. This happens automatically and unconsciously. Occasionally, during therapy, memories flood back and the client dramatically relives the episode. Although this may be frightening for the client and the psychologist, it can be therapeutic if handled appropriately. To measure the progress and outcome of treatment, the client should fill out the PTSD checklist on a weekly basis. If a comorbid problem is present, the client should also fill out a weekly measure of that problem. At the completion of treatment, the therapist should re-administer the clinician-administered PTSD scale and the paper and pencil questionnaires that were delivered at the beginning. This way, the psychologist can make a judgment of how much improvement was made, and if not much improvement was made, maybe a different type of therapy will be needed. Thank you, and good luck treating PTSD.